Hello, my name is Rick Lomax from the Sustainable Development Unit. Today I'm going to talk you through the Health Outcomes of Travel tool and specifically to take you through the primary care interface. The interface is useful for several different types of organisation. Clinical Commissioning Group or CCG can assess their own impact. It also looks at the impacts of primary care within either a CCG boundary, a regional boundary or a national boundary, and for those CCGs who co-commission primary care, they can see the CCG's own impacts alongside the primary care they co-commission. So on opening the tool, you should see the introduction slide here, and to get to the primary care interface, just look at the red tab at the bottom that says primary care and click that. This is what the primary care user face looks like. The first thing you need to do is to select your CCG or the boundary you're trying to assess. By clicking the drop down list, you can either see the different PHE or NHS England boundaries, or if you scroll further down, there's the list of all the CCGs in England. For this analysis, we're just going to look at all primary care, so that's the impacts of all primary care and all CCGs within England. We're going to select the baseline year of 2015. When you're using the regional or the all primary care, you need to make sure this is set as 2015, but if you're picking a specific CCG, then you can change that to be the most recent year you've got the information for. The next couple of cells are really useful to track who's performing the analysis, the date it's being performed, and name the scenarios you're trying to map or achieve. Scrolling down, there's the information here. So the tool allows you to model up to 5 different scenarios. And in this example, we're going to look at how we can encourage CCG and primary care staff to look at active travel on their daily commute to work. What I'm going to do with scenario 1 is call this the actual baseline. The tool uses various assumptions and public available data to build a default baseline. We've tried to make this as accurate as possible, but creating an actual baseline in scenario 1 allows you to overwrite any of these assumptions to make sure your baseline is as accurate as possible. In this example, I'm going to use year 2015. And as mentioned, we're going to model increase in staff commuting from active travel. And we're going to assume the modal share increases up to 6%. We're going to model that as the 2019 year. It's really important as well to create business as usual scenarios for the same year you're modelling. What the tool does with the year information is to model the average vehicle within that year aligned to Department for Transport estimations of the change in fuel type and efficiency over time. So for instance, the electrical proportion of vehicles on the road is slowly increasing. So using a business as usual, make sure you're comparing the two scenarios like for like. We're also going to say whatever the initiative is also increases staff modal share of active travel up to 12% by the year 2021. Again, it's really important to create a business as usual, and we'll select the same year for direct comparison. So that's the naming of the scenarios done. And what you'll notice as you put in this information, the information in terms of miles, CO2, quality loss, pound loss in terms of effects to health and society from travel, and also the active healthy benefit, which is the positive side of active travel. These information will start to display. You also see below some of the key graphical outputs from the tool start to become displayed. As you scroll further down, we can go to part B, data entry, and we can start editing some of the specific numbers within the tool. So one thing to note on the functionality of the interface is a lot of the cells are locked. However, those highlighted blue, i.e. these here, these are the values that can be changed. By default, all of the scenarios replicate the assumed baseline that's calculated by the tool. So there's lots of information in the tool that you can change to make your actual baseline or your scenarios more accurate. Firstly, you can change the number of staff as FTEs employed by CCGs and by primary care organisations. And you can also change the patient activity levels for GPs, dentists, pharmacy and eye care. These numbers are taken from various national statistics. You can also change the number of journeys per the different activity types. So changing the number of journeys per GP visit or eye care visit, for instance. And you can also add accompanying persons. So if there's visitors that are also going to accompany the patient by their own mode of transport, then this also can be added. You can also change is the average distance per each of these visits. These are based on some national assumptions, but you can change these if you can do some postcode and mapping or some travel survey work to update these information to more locally accurate or specific to analysis you're undertaking. What we can also do is change the business mileage. This is all assumed by car. You can also change the patient travel mode of share. So that's the different types of vehicles or modes of transport used by patients to access primary care. These are set as DFT, Department for Transport, national averages, but if you've done a patient travel survey, for instance, you can overwrite these figures to make them more accurate. What you can also change is the composition of car fleet, the fuel makeup for the vehicles that are used as part of patient travel. As you can see, these values change over the years. As I said previously, this reflects the projection by Department for Transport. Next, we can model the changes in staff commuting. And as we said in this scenario, we're going to assume the increase of modal share by active travel increases by 6%. So I'm going to assume in this scenario that that is evenly spread between walking and cycling. So I'm going to model these numbers by increasing the modal share of walking by 3% and increase the modal share of cycling by 3% and assume that this is avoiding the modal share by driving. And in the further scenario, it's going to be a modelled increase of overall by 12%. So I'm going to share that 6% each on walking and cycling. Again, that's going to directly replace car travel. When you do change these figures, just make sure the cells across the bottom still equal 100% as not to skew your analysis. As before, you can also change the composition of the car fleet by staff commuting. So if you've done some staff travel surveys, you can edit the vehicle fuel type as well. It's the same for business mileage. You can also change these figures if required. One thing the tool also does is allow you to factor in the health impacts from accidents. The tool auto assumes local average impacts and number of incidents and severity of incidents based on staff commuting and patient and visitor travel. What the tool doesn't do is include that into business mileage as well. So you can leave it as no data, which is the default, which assumes there's no road traffic accidents related to business mileage. Or you can, from the drop-down menu, change it to local authority average or user-defined. If you select user-defined, you need to specify exactly what those number of incidents are. In this scenario, I'm going to assume it is as no data and leave it as default 0. Once you've completed that, that's the last bit of data you need to change and edit, and we can start to scroll down and look at the detailed results. So scrolling down to the results section, first of all you have all the results for patient and visitor travel. You can see the overall distance travelled, the overall litres of fuel or kilowatt hours of electricity used. The impacts are also shown in nitrous oxide emissions and also PM2.5 particulate matter release for the different types of transport. You also see the health impacts in terms of qualities, life years lost and also the economic cost. Then comes the accidents, the noise, climate change, and the total impacts of patient and visitor travel. Scrolling further down, you can see the staff business travel impacts, same as above in terms of order, and also we haven't changed any of the scenarios, so therefore this information is relatively the same between the different scenarios. The only impact to see is the change in fuel mix as aligned to the DFT projections. Shows changes, but there's no difference between the two scenarios for the same year. And at the bottom we've got the staff commuting information, so we're going to start to see changes between the scenario we're modelling and the BAU. For instance, if you look down to the total NOx emissions, because there's less vehicles being used for staff commuting and more people are using active travel, you can see that the NOx impact has reduced between the two scenarios. So you can see between these 2 years there's a drop of around 8 tonnes. Between these years there's a drop of about 15-16 tonnes. We can also see the impacts on climate change, greenhouse gas emissions. So there's a drop between the two scenarios of the same year, and the same again with the further increase in active staff travel. There's an even larger drop. When it comes to the total cost impacts, you can see the difference between 2021 scenarios is roughly 2.5 million. One thing the tool does is understands the health impacts of regular active travel. So there's quite a significant increase in the physical activity because there's more staff using active travel on their route to work. And you can see the economic benefits of this rise substantially. So the difference in the 2021 scenario, where 12% of the modal share has increased to active travel, there's a significant £5.7 million economic benefit from avoided healthcare costs because staff are fitter and healthier. Scrolling back up to the top, we can see the changes in the graphical outputs. The most obvious one here is the changes to staff commuting modal share. You can see the increase of active travel presented in the graphs. Scrolling further up, you can see the change in monetized damage by impact type, and you can see the two scenarios for 2021. You can see the drop in overall monetary impact, and also the summary results at the top have also been updated aligned to the new scenarios. So you can see there's the active health benefit increase, which is a positive cash, and the health and societal impact loss difference between the same years across the different scenarios. So that is a quick introduction to the primary care interface. If you look at the SDU website, there's other videos for the other interfaces showing different functionality, and there's also a full user guide that has a similar walkthrough that may be useful.